when we think about your bladder cancer, majority of bladder cancer is urothelial carcinoma, and there's been a tremendous number of advances in the treatment of urothelial carcinoma now with multiple positive studies, we have antibody-drug conjugates, immunotherapy. But when we look at the variant histologies, squamous cell, adeno, small cell, a lot of the data, the best data now comes from studies from over 15 years ago, and it really represents an unmet need. And so we're just trying to look at how do we treat these different patients. And overall, we see in the WHO 2022 classification, this is a wide variety of tumors, and each tumor is quite different. When we think about, oh, it's just a variant histology, well, small cell carcinoma of the bladder is nowhere similar to what we see with adenocarcinoma. And so I think it's important when we think about this, how do we approach this overall? I think the first step is small cell carcinoma of the bladder is really a unique entity, which needs systemic therapy, regardless of what stage you're at with the platinum etoposide, even for the smallest amount, with aggressive local control. A lot of the other histologies, if they arise in the setting of predominant urothelial carcinoma, studies have shown, even in the neoadjuvant setting with the VESPER trial, there's just predominant urothelial, some minority variant, that those patients do just as well as those with pure urothelial. But for those with pure variant histology, I think it's much more challenging. And really, in the localized setting, pure variant histology, specifically squamous cell, adenocarcinoma, the standard care is to go right to surgery. When we start getting into the metastatic setting, that's where clinical trials are really important to figure out what the best approach is. And a lot of the data is based on cytotoxic chemotherapy, looking at carboplatin and taxane, potentially fosfamide, based on a study of less than 20 patients, which is still quoted to this day. So at Dana-Farber, we actually took an initiative to say, hey, can we do something more for these patients? And we looked at the combination of nivolumab and ipilimumab in variant histologies. There's a wide trial, 60 patients were enrolled across different rare tumors. And I think what this trial showed is we were able to enroll 60 patients with really rare tumors in less than 18 months. And we saw some activity in the bladder cohort, and now we're expanding the bladder cohort. We saw some activity in the small cell, and we're expanding it. So it's a model for these rare tumors to say, hey, we can't study these. We can. We just need to work together. And there's really preliminary, exciting data looking at the Nectin-4 and TROP2 and some of the variant histology, and shows that it's there. And so as we look at these new advances in traditional urothelial carcinoma, akin to what we saw with immunotherapy, we can take that data and hopefully do similar trials, look at these variant histologies with these new agents. With these tumors, we really don't know what is the best treatment. We saw data with nivo-ipi, a 37% objective response rate, which is amazing. 50% in those patients with small cell at the bottom, those were durable. And we saw responses across histologies, but we can do better. And so without a doubt, I think genomic sequencing is important. When we look at adenocarcinoma urachal, if they do the genomic sequencing, it's far more akin to colorectal carcinoma than it is to urothelial carcinoma. And so sometimes finding that genomic sequencing may lead to target that can be used, and specifically trials like the NCI match or other trials using that targeted therapy may be the approach. I think it's always a question, if we find this target, does it work in that tumor? But I think in this area where we really are exploring new options, genomic sequencing is incredibly important as we look to try to find new targets in this situation. So I think overall, the treatment of variant histologies in bladder and uptract carcinoma really is an unmet need. And I think that as a group, we can certainly work together to do more. And I think what we showed with our trial, where we were able to enroll 60 patients with rare tumors in under 18 months from 4 sites, that the patients are there, patients are excited to do this. And so if we can work together and come up with smart designs, I think it's important. I mean, obviously the purest approach would be like, oh, we're gonna do a study in squamous cell or adeno. Well, that's fantastic, but that can take some time. And so sometimes these trials include all the histologies, and then looking for a signal and expanding can really be the way to move forward.